Hello everyone, I'm Marbe Ereño from Section F. I'm here to discuss to you about leukocytosis. So the next slide is the image shows the difference between having a normal white blood cell, increased white blood cell, and then the decreased white blood cell. When the WBC decrease, it's called leukopenia, which is in the right side. When WBC increase, it's called leukocytosis, which is in the left side. In the middle is the normal leukocytes in the blood. So you can see the differences of the three. So what is leukocytosis? It is a condition that characterized by an elevated white blood cell or WBC count in the blood, typically above 11,000 cells per microliter in adults. White blood cells or leukocytes are part of the immune system and help the body fight infections and other diseases. So, when we say leukocytosis, ito ay isang kondisyon na dumadami ang WBC sa ating dugo or blood. So, nais ko lang klaruhin na ang leukocytosis is not a disease itself, but rather a sign that the body is responding to a various stimuli, such as infections, inflammation, stress, trauma, or certain medical conditions like leukemia. So, pag naranasan ito ng ating katawan, magkakaroon ng pag-increase ng ating WBC na tinatawag na itong leukocytosis. There are several types of leukocytosis based on the predominant type of white blood cell. There are 5 types. The first one is the neutrophilia, increase in neutrophils often due to bacterial infections or inflammation. The second is the lymphocytosis, increase in lymphocytes often seen in viral infections. The third type is the monocytosis, elevated monocytes associated with chronic infections or inflammatory diseases. And then the eosinophilia or the higher eosinophil count, typically related to allergies or parasitic infections. And then lastly is the basophilia, increase in basophils, which is rare but can be related to allergic reactions or certain bone marrow diseases. The next slide is the normal leukocyte life cycle and responses. So, the life cycle of leukocytes includes development and differentiation, storage in the bone marrow, margination within the vascular species, and migration to tissues. Stem cells in the bone marrow produce cell lines of erythroblasts, which become red blood cells, megakaryoblast, which become platelets, and then the lymphoblasts and myeloblasts. Lymphoblasts develop into various type of T and B cell lymphocytes. Myeloblasts further differentiate into monocytes and then granulocytes. A designation that includes neutrophils, basophils, and eosinophils. Once WBCs have matured within the bone marrow, 80 to 90% remain in storage in the bone marrow. So the next slide has a table, and this table is all about white blood cell count variation with age and pregnancy. So, what are the normal white blood cell count for a person? So, the normal blood count or the normal white blood count for a person is between 4,000 to 11,000 cells per microliter of blood. So here, there is a changes for normal total leukocyte count for the following patient characteristics, like in newborn infant. So in newborn infant, the normal total leukocyte count is 13,000 to 38,000 per cubic millimeter. Why? Because tend to have higher WBC due to physiological stress, exposure to a new environment, and response to potential infections. However, in infant, for 2 weeks of age, is 5,000 to 20,000 per cubic millimeter. It begins to decrease as the immune system starts to stabilize and adapt to the environment outside the womb. And for adult, of course, it's 4,500 to 11,000 per cubic millimeter. Have a stable range that reflects a fully developed immune system. Variations within this range can be caused by infections, stress, inflammations, or etc. And lastly is the pregnant female or third trimester. When you are pregnant, your normal total leukocytes counts will be changed. it will be 5,800 to 13,200 per cubic millimeter, because WBC tend to be elevated in pregnancy, especially in the third trimesters or 28 weeks, as part of the immune adaptation to protect both mother and the fetus. This increase prepares the body for potential blood loss and the stress of delivery. So, the frequency of leukocytosis varies widely from routine encounters in primary care settings or such as infections to more serious hematological conditions seen in specialized care. It is often discovered through routine blood tests and may prompt further investigations to determine the underlying cause. Let's move on to the prevalence. Leukocytosis itself does not cause specific symptoms, but these signs arise from the conditions that is causing the elevated WBC count. Proper diagnosis and treatment depend on identifying the underlying cause, such as infections, stress-related causes, chronic diseases, and hematologic disorders. So the infections, it is one of the most common causes of leukocytosis, especially bacterial infections. Stress-related causes, physical stress, surgery, or trauma can lead to temporary leukocytosis. And then the chronic diseases, it is conditions like rheumatoid arthritis, Crohn's disease, or asthma may also lead to chronic elevations in WBCs. And lastly is the hematologic disorders. In certain cancers of the blood or bone marrow, example leukemia, leukocytosis can be significant and persistent. The next slide is all about the signs and symptoms of leukocytosis. Often depend on the underlying cause such as infections, inflammations, or other conditions, but common signs and symptoms include fever, fatigue or general weakness, shortness of breath or difficulty breathing, dizziness or lightheadedness, excessive sweating, unexplained weight loss, bleeding or bruising easily, pain or tenderness in specific areas, infections-related symptoms, and then the inflammatory symptoms. So in fever, it is often due to an underlying infection or inflammation. However, in shortness of breath or difficulty breathing, particularly if leukocytosis is caused by lung or respiratory issues. And then in excessive sweating, it is arise especially at night. And then the pain or tenderness in specific areas such as the abdomen or joints. And then in the bleeding or bruising easily, it is arise if associated with a blood disorder. And then the inflammatory symptoms like redness, swelling, and warmth in certain body areas, depending on the location of the inflammation. So the leukocytosis itself does not cause specific symptoms, but these signs arise from the conditions that is causing the elevated WBC count. Proper diagnosis and treatment depend on identifying the underlying cause. So let's move on to the laboratory and diagnostic tests of leukocytosis. So first one is the complete blood count or CBC with differential. It determines the total WBC count and measures the different type of white blood cells or neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And then the second one is the peripheral blood smear. Examines blood cells under a microscope to check for abnormal cells and morphology. So in abnormalities in cell shape, size, or appearance can provide close to infections, leukemia, and other disorders. The third one is the bone marrow aspirations and biopsy. It assesses bone marrow cellularity and the presence of abnormal cells. So here are the findings of this is useful if there is a suspicion of bone marrow disorders, leukemia, or myeloproliferative diseases as a cause of leukocytosis. And then the fourth one is the infection testing, or example like cultures. Identifies infections causing leukocytosis, example blood, urine, or sputum cultures. Positive cultures can pinpoint bacterial, viral, or fungal infections. So the fifth one is the immunological and serological test. Detects specific infections, example viral serologies, or autoimmune markers. So the findings of this is it is elevated levels of specific antibodies or markers may indicate conditions like HIV, Epstein-Barr virus, or autoimmune diseases. The sixth one is the flow cytometry. Helps diagnose leukemias and lymphomas by identifying abnormal cell populations. And then the genetic and molecular testing. It is mutations, example BCR, ABL, JAK2, help confirm specific types of leukemia or blood cancers. And lastly is the erythrocyte sedimentations rate, or ESR, and the C-reactive protein, or CRP. Non-specific tests for inflammations. Elevated levels indicate an inflammatory process that may correlate with leukocytosis. So, these 8 laboratory and diagnostic tests help pinpoint the cause of leukocytosis, aiding in diagnosing and managing underlying conditions effectively. Okay, so let's move on to the pathophysiology and treatment algorithm of leukocytosis. So first, I will discuss the factors, which is the predisposing factors and precipitating factors. So in predisposing factors, there are chronic inflammatory diseases, allergies and asthma, autoimmune disorders, smoking, genetic factors, and then the stress or obesity. However, in precipitating factors, there are infections, acute inflammations or injury, medications, acute stress, malignancies, tissue necrosis, immune responses, and metabolic disorders. So, if these factors arises, it results to leukocytosis, which is the white blood count or the white blood cell count will be increased greater than 11,000 per cubic millimeter. And if this happened, it obtained a complete blood count or CBC or the peripheral smear. If the leukocytosis confirmed after this, if no further workup, and if yes, the patient history and physical examinations, example, pregnancy, newborn, splenectomy, smoking, or medications. If yes, no further workup necessary, and then if no, the patient presents with weight loss, fatigue, night sweats, fevers, abnormal red blood cell and platelet count, immature leukocytes forms or blasts, chronic durations, or weeks or years. History of or risk factors for malignancy, splenomegaly, lymphadenopathy, bruises. If yes, consider it malignancies. Hematology or oncology consultations, consider additional testing to include flow cytometry, cytogenetic testing, or molecular testing of the bone marrow or peripheral blood. And then if yes, and then if no, consider non-malignant etiologies. Which cell line is affected? If the cell line is affected, about neutrophilia, is greater than 7,000 per cubic millimeter, the infections or the chronic inflammations, recent stressors, medications, induced bone marrow stimulations, splenectomy, tobacco use, considered medical, medication, family troubles, sick, contact, surgical, and social history, or SRR, CRP, and ANA measurement, pathogen isolation, blood culture, lumbar puncture, additional imaging, or systems specific. However, if the lymphocytosis or the cell line that affected or the greater than 4,500 per cubic millimeter, infections or viral pertussis, hypersensitivity reactions, considered sick, contact, and immunization history, imaging or chest radiography, pathogen-specific testing, or viral panels. However, if the monocytosis is the line affected, greater than 880 per cubic millimeter, infections or Epstein-Barr virus, tuberculosis, fungal protozoa, rickettsia, autoimmune disease, and splenectomy. Considered it a sick contact, surgical and travel history, imaging or chest radiography, pathogen-specific testing, mononucleus spot test, purified protein derivative ESR, CRP, and ANA measurement. And then if the eosinophilia are the line affected, it is greater than 500 per cubic millimeter. Allergic conditions, eosinophilic esophagitis, medications, reactions, dermatologic conditions, parasitic infections. Considered medications, travel history, full skin examination, skin biopsy if warranted, allergy or immunology testing, parasite-specific testing, or stool, ova, and parasites upper endoscopy. However, if the vasophilia are the line affected of the leukocytosis, it is greater than 100 per cubic millimeter, search for malignancy or allergies conditions much less likely. Okay, so let's move on to the medical or surgical pharmacology management. So in medical and surgical management, there is infection-related leukocytosis, inflammatory causes, and trauma or post-operative leukocytosis, and lastly is the splenectomy. So in infection-related leukocytosis often results from infections where addressing the infection through antibiotics or antiviral treatments typically reduces WBC levels. Additional supportive care such as fluids and antipyretics may be needed if fever or dehydration is present. However, in inflammatory causes, for chronic inflammatory diseases like rheumatoid arthritis or inflammatory bowel disease, managing the underlying inflammations with disease-modifying agents such as NSAIDs or corticosteroids can reduce leukocytosis. In trauma or post-operative leukocytosis, post-surgical patients often exhibit reactive leukocytosis, which typically resolves without intervention. Monitoring and supportive care are generally sufficient unless complications arise. Lastly is the splenectomy. Splenectomy can cause persistent leukocytosis, which is generally benign but requires monitoring to prevent infection risks due to immune changes post-surgery. In pharmacologic management, there are targeted therapy, colony-stimulating factors, chronic myeloproliferative disorders, and targeted therapy, medications causing leukocytosis, example corticosteroids, lithium, may require adjustment if leukocyte counts become problematic. However, in colony-stimulating factors, in certain cancers or post-chemotherapy recovery, medications like granulocyte colony-stimulating factors are administered to boost WBC counts intentionally. However, adjustments may be needed if counts become excessively high. In chronic myeloproliferative disorders, conditions such as chronic myeloid leukemia or polycythemia vera may require more intensive therapies, including targeted agents like tyrosine kinase inhibitors or, in some cases, chemotherapy. These drugs act by inhibiting abnormal cell proliferations at the molecular level. For suspected leukemias or hematologic malignancies, bone marrow analysis and cytogenetic testing can determine the WBC origin. With treatments tailored to the cancer type, these cases may also require adjunct therapies such as transfusions or specific medications like hydroxyurea to reduce WBC counts in acute settings. So let's move on to the nursing management. So there are 5 nursing management. The first one is the assessment and monitoring. Under this is the monitor WBC levels, vital signs, assess for infections, and monitor symptoms. In monitor WBC levels, regularly review laboratory results to track changes in WBC counts and monitor for worsening leukocytosis or signs of infections. However, in vital signs, regularly monitor temperature, pulse, respiration, and blood pressure. Fever can indicate infections. In assess for infection, look for signs of infection such as redness, swelling, pain, warmth, and purulent drainage. In monitor symptoms, check for any symptoms that may indicate the underlying cause such as fatigue, weakness, weight loss, or night sweats. In number 2, patient education. In patient educations, there are infection prevention, medication adherence, and recognizing symptoms. In infections preventions, teach the patient and family proper hand hygiene and ways to prevent infections, example, avoiding large crowds. However, in medication adherence, ensures the patient understands the importance of taking antibiotics or other prescribed medications as directed, and recognizing symptoms. Educate on when to seek help, such as signs of fever, chills, or worsening symptoms. So in number 3 of nursing management, this is the supportive care. Under this, encourage rest, hydration and nutrition, and pain management. In encourage rest can help the body fight infection and reduce the physiological stress that might be causing leukocytosis. In hydration and nutrition, encourage adequate hydration and a balanced diet to support immune function. However, in pain management, provide appropriate analgesics if the patient is experiencing pain, especially from inflammatory causes. However, another nursing management is collaborative management. Under this is coordinate with healthcare providers, administer medications, and follow infection control protocols. In coordinate with healthcare providers, work closely with doctors, pharmacists, and laboratory staff to manage the patient's condition. In administer medications, provide antibiotics, antipyretics, or anti-inflammatory drugs as ordered. In follow infection control protocols, if leukocytosis is due to an infection, ensure strict adherence to infection control measures to prevent the spread. And then lastly is documentation and reporting. Document WBC count, trends, vital signs, and any changes in the patient's condition. Report significant changes to the healthcare team promptly for timely intervention. Also, effective nursing management of leukocytosis involves comprehensive assessment, early intervention, patient education, and multidisciplinary collaboration to address the underlying cause and promote recovery. So the next slide, which is the prognosis. The prognosis of leukocytosis, which refers to an elevated white blood cell or WBC count, varies significantly depending on the underlying cause, patient's overall health, age, and how promptly the underlying condition is treated. Leukocytosis itself is a symptom rather than a disease, often indicating an infection, inflammation, stress, trauma, allergies, certain medications, or more serious conditions like blood disorders and cancers. And then lastly is the key prognostic factors for leukocytosis. The first one is the infection and inflammation. There are short-term and then long-term prognosis. In short-term prognosis, if leukocytosis is due to infections such as bacterial infection, it often resolves once the infection is treated. However, if long-term prognosis for chronic infections or conditions, example tuberculosis, autoimmune diseases, leukocytosis may persist longer, and managing the primary condition is essential for better outcomes. The second one is the stress or physical trauma. In leukocytosis in response to physical or emotional stress typically resolve once the stressor is removed or the body recovers from trauma. Number 3 is the medications or allergic reactions. Medication-induced leukocytosis is reversible once the medication is adjusted or discontinued, provided there is no lasting damage to the immune system. And number 4 is the chronic diseases, example, autoimmune conditions. Leukocytosis due to chronic diseases requires ongoing management of the underlying disease. Prognosis depends on the conditions, progressions, and response to treatment. Number 5 is the malignancies, example, leukemia. Leukocytosis caused by blood cancers or malignancies varies widely. In such cases, the white cell count can be extremely high, and prognosis depends on the type, stage, and treatment of the cancer. Early detection and treatment often improve outcome. And lastly is the age and overall health. Prognosis, younger, healthier individuals may recover faster from leukocytosis compared to older individuals with coexisting health issues. And that will end my report. Hope you learned something in my discussions. Thank you.